Welcome to lecture 25 on long-term ACL outcomes. I am Major Arun, and in this session we will focus on what happens after immediate success of ACL reconstruction when the athlete has returned to play. But we now need to think about re-injury prevention and lifelong health of the joint. We often celebrate short-term return of sports, but reality is that ACL injury is not just an acute event. It is a chronic condition that influences future injury risk, joint integrity, and overall quality of life. This lecture will address long-term consequences like osteoarthritis of knee, predictor of poor outcomes, the role of secondary prevention programs, and the importance of structured follow-up using both clinical examinations and patient-reported measures. By the end, you will understand how to approach ACL rehabilitation not just as a 6 to 9 month program, but as a lifelong joint health strategies. By the end of this lecture, our main objectives is to explore the long-term consequences of ACL re-injury and reconstruction, especially re-injury risk and the surveillance of post-traumatic osteoarthritis. Secondly, we will learn how to apply validated tools such as International Knee Documentation Committee Subjective Knee Form and Quality of Life Scales and the patient's acceptable symptom state or PAS in follow-up evaluations. Third, we will discuss how a criteria-based return to sports readiness, when combined with longitudinal monitoring, can improve long-term joint health. Finally, we will emphasize the need for individualized, milestone-based rehabilitation and the critical role of psychological readiness in sustaining long-term outcomes. These objectives shift our mindset from short-term milestones to a continuum of care that extends well beyond first return to play. Goals of this lecture. The primary goal of ACL management is to restore joint stability, rebuild function, and reduce the risk of secondary injuries. But despite good outcomes in terms of graft stability, two persistent challenges remain: the high injury risk in younger athletes and the long-term development of osteoarthritis of knees. Research consistently shows that ACL reconstruction improves stability, yet up to 50% of patients may still develop radiographic signs of osteoarthritis within 15 to 20 years. This means our responsibility as clinicians or physical therapists does not end with return to play. It extends into lifelong joint surveillance and activity modifications. In addition, shared decision making remains essential. Operative and non-operative pathways each have implications of long-term outcomes, and these must be discussed with athletes early in their rehabilitation journey. Long-term problems. The risk of second ACL injury is highest within the first 2 years after return to sports, especially in younger athletes under 25 years of age. This may involve graft rupture or a new injury to the contralateral limb, both of which are devastating, and the performance and long-term health affected by the second injury of ACL in the same limb or contralateral limb. Over 10 to 20 years, the risk of radiographic osteoarthritis knee increases substantially, regardless of reconstruction, though reconstruction reduces the severity compared to non-operative treatment. Early return to sport before 12 months is consistently linked with higher rates of re-injury and potentially faster osteoarthritis progression. Thus, the long-term problem is dual, preventing second injuries in the short term while minimizing osteoarthritis risk in the long term.
Among the long-term complications following ACL reconstruction, patellofemoral joint osteoarthritis deserves a particular attention. Altered joint biomechanics, quadriceps weakness, and persistent patellofemoral maltracking can accelerate degenerative changes in the compartment. Unlike tibiofemoral osteoarthritis, patellofemoral involvement is strongly associated with anterior knee pain, stair negotiation difficulty, and reduced return to high demand sports. Clinicians must remain vigilant in early identification through careful functional assessment and imaging when indicated. Preventive strategies include restoring full extension, optimizing quadriceps and hip strength, and addressing movement patterns that overload the patellofemoral joint. Emphasizing these measures in rehabilitation is critical to delay or mitigate long-term patellofemoral osteoarthritis. In the post-ACLR patient's right knee, as shown in this video, the patella does not glide centrally in the femoral groove. Instead, it drifts laterally at terminal extension, indicating patellar maltracking. This commonly arises from quadriceps weakness, particularly the VMO muscle, leading to imbalance and increasing the risk of long-term anterior knee pain.
Long-term outcomes. Several predictors can help us identify athletes at risk for poor outcomes. The main is the persistent quadriceps weakness, even before surgery, strongly predicts reduced function at 6 to 24 months and may accelerate early degenerative changes. Concomitant injuries to the medial meniscus or articular cartilage worsen the prognosis, as they directly increase the likelihood of osteoarthritis progression. Psychological readiness is another important key factor. Athletes with high kinesiophobia or fear of re-injury or low ACL return to sports index scores tend to underperform, delay return to sport, or sustain further injuries. Finally, residual laxity and a positive pivot shift early after surgery are associated with worse outcomes over the long term. By identifying these risk factors, clinicians can modify rehabilitation program and enhance monitoring intensity during the entire rehabilitation period, and as well as completion of complete ACL rehabilitation for long-term effects. Can we prevent secondary injuries after post ACLR patient? Yes. Evidence strongly supports the role of structured secondary prevention programs. Few protocols like FIFA 11 or FIFA 11 Plus in case of football, the PEP program, that means prevent injury and enhance performance, and other neuromuscular warm-ups like dynamic warm-ups significantly reduces re-injury risk by reinforcing safe landing mechanics and improving strength. These programs emphasize jump landing corrections, plyometrics, agility drills, and reactive control, exactly the deficits we see in post ACLR athletes. Importantly, progression within these programs should remain criteria based, not time driven, ensuring athletes only advance when mechanics and tolerance are sound. By integrating these warm-ups into long-term training, we reduce, or definitely we can reduce not only ACL re-injury, but also improve overall athletic performance. What is the consensus or recent evidences on prevention of secondary injuries in ACL injured patient or post ACLR athletes? Monitoring does not stop after clearance of play. Adverse events such as graft rupture or contralateral injury are most likely within the first 6 to 12 months, and early reporting is critical. However, comprehensive assessment requires at least 2 years of structured follow-up with over 80% retention to capture both clinical and patient-reported outcomes. Laxity, both anteroposterior as well as rotatory, should be recorded promptly when detected, as it may signal impending problems. For osteoarthritis surveillance, MRI is preferred for detecting early changes beyond 5 years, while radiographs are useful for established osteoarthritis. This structured long-term follow-up gives us a complete picture of joint health over time. Something important about patient-reported outcomes. Patient-reported outcome measures provide vital insights beyond that we see on examination. The International Knee Documentation Committee Subjective Knee Form is the gold standard knee-specific measure and should be part of every follow-up protocol. Health-related quality of life scale assess the broader impact of ACL injury on daily life and well-being, not just sport. Lyshan and Tegner scores add information about activity and its level and functional ability in real-world settings. The Patient Acceptable Symptom Scale provides a clinically relevant threshold, essentially asking whether the patient feels their current state is acceptable or not. These measures ensure that return to play decisions are athletes centered and not just based on clinician or test based criteria. That's why we should ensure comprehensive rehabilitation as well as overall long term monitoring of knee joint. What's the radiology is telling about long term outcomes? Long term imaging studies provide very important lessons. Malik and colleagues followed patients with open bone patellar tendon bone grafts for 17 to 20 years. They found that osteoarthritis rates were lower in reconstructed knees compared to a non-operatively treated knees. But osteoarthritis still developed in many cases. Most reconstructed knees remained stable on International Knee Documentation Committee grading, confirming the mechanical success of anterior cruciate ligament reconstruction. However, the presence of meniscal injuries, chondral injuries, and residual laxity were the strongest determinants of who developed osteoarthritis. This reinforces the idea that reconstruction alone does not eliminate risk. Joint preservation strategies, especially meniscus care and chondral repair, are equally important. Role of meniscus in long-term outcomes. This is the very important point we should all remember. The meniscus plays a critical role in long-term joint health after ACL injury. Secondary meniscal injuries accelerates osteoarthritis progression by increasing joint contact stresses. Patients with anterior cruciate ligament tears with meniscus lesions who are not reconstructed face much higher osteoarthritis risks compared to those who undergone anterior cruciate ligament reconstruction. Preservation of this meniscus during reconstruction through repair or partial preservation rather than resection significantly improves long-term outcomes. Thus, modern ACL surgery emphasizes meniscal preservation whenever possible. Principle that must also be reinforced in rehabilitation by protecting the healing tissue. What are the clinical implications of these outcomes? What does this mean for our day-to-day practice? First, structured, evidence-based rehabilitation remains the cornerstone of prevention. Poor or rushed or accelerated rehabilitation increases long-term risk. Secondly, osteoarthritis surveillance should begin after 5 years with a combination of clinical examination, patient-related outcome measures, and imaging when indicated. Follow-up must be standardized across the world with at least 2 years of comprehensive patient-reported outcome measures collection to track recovery trajectories. Finally, shared decision making is crucial. We must openly discuss expectations, re-injury likelihood, and osteoarthritis risk with patients so they can make informed decision about their sport and activity levels once they complete rehabilitation process. To conclude, anterior cruciate ligament reconstruction restores stability and allows higher levels of joint function, but it does not fully prevent from the development of osteoarthritis of knee. Long-term outcomes depend not only on surgical success, but also on secondary prevention, rehabilitation quality, and structured monitoring protocols. We must view anterior cruciate ligament management as a lifelong process with emphasis on activity optimization, periodic surveillance, and injury prevention strategies. By combining clinical examination, patient reported outcome measures, imaging modalities, and psychological readiness, we ensure both safe return to play and long-term joint health. This lifelong joint health approach shifts the focus from short-term fix to continuum of care. These concepts are supported by multiple high-quality sources. The 2020 Panther Symposium consensus highlights clinical outcome benchmarks. Mihalik's long-term cohort study provides evidence of osteoarthritis risk even after reconstruction, and recent reviews by Jenkins and others emphasize the importance of structured rehabilitation and standardized follow-up. Together, they reinforce principle that ACL management is both an acute intervention and a long-term health strategy.
For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm-up and concluding with an appropriate cooldown. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.